Hello, everyone. Welcome to this webinar. We will give a couple of minutes for people to join, and we will be starting soon. Okay. Okay, I see already that several attendees are in, so I think for the sake of time, we are going to start. Welcome to this webinar. The first Wealth is Health. It's a pleasure for e-MFP, for the European Microfinance Platform, to host this webinar in the framework of the European Microfinance Award 2021, which is dedicated to the topic of inclusive finance and healthcare. I'm Gabriela Erice, Senior Microfinance Officer at e-MFP and the person in charge or responsible for the award within our team. The European Microfinance Award is an annual prize that runs since 2005 and is jointly organized by the Directorate for Development Cooperation and Humanitarian Affairs of the Luxembourg Ministry of Foreign and European Affairs, e-MFP, and the Inclusive Finance Network Luxembourg. It attracts applications from organizations that are active in financial services around the world and that are innovating in a particular area of financial inclusion. And it serves two parallel goals. On the one hand, rewarding excellence, and on the other, collecting and disseminating the most relevant practices for replication by others. In 2021, the focus of the award is on how the financial inclusion sector can facilitate access to quality and affordable healthcare for vulnerable populations. The award is already running. It was launched in March and received 43 applications from organizations operating in 32 countries. Applications are currently going through the selection process that takes place in several stages, and the winner will be announced on the 18th of November at the award ceremony that takes place during the European Microfinance Week, e-MFP annual conference. With the aim of raising awareness on this fascinating and, we have to say, more relevant than ever topic given the pandemic context we are in, e-MFP decided to organize this webinar and invite a group of sector experts to share their views and experience. I'm delighted to introduce you to the 5 panelists that are with us today. I'm going to start with Bobby Gray, Research Director at Grameen Foundation. She will be the moderator. She'll be moderating the discussion. And Bobby has over 15 years of experience in research, evaluation, and monitoring activities to determine solutions for measuring and assessing the social performance and impacts of integrated financial and non-financial services for adults and youth across a variety of client outcomes dimensions. She has worked with in-country research teams, academic researchers, and partner organizations, including microfinance institutions and NGOs across Latin America, Southeast Asia, and Africa. Together with Bobby, we have 4 speakers. We have Lisa Morgan. Lisa is a technical specialist at the ILO's Impact Insurance Facility, where she provides expertise on inclusive insurance with a specific focus on health. Originally from South Africa, Lisa has over 2 decades experience in actuarial and related work in Europe, Africa, and Asia. Before joining the ILO, she worked in Milliman's health practice and at PricewaterhouseCoopers in London. Lisa is a qualified health actuary through the Institute and Faculty of Actuaries in the UK. We also have with us Peter Rede. Sorry for my pronunciation of the surname, Peter. Hope it's okay. Peter is a senior consultant and also a German actuary with more than 3 decades experience in insurance, reinsurance, and microinsurance. He worked at German and international commercial insurers and reinsurance until 2007, when he joined Aga Khan Agency for Microfinance to develop microinsurance in Africa and Asia. He then worked for the ILO and the World Bank, and since 2019, he's providing consultancy service on topics related to insurance and disaster risk financing. We have also Barbara McNoney, president of EA Consultants, a development consulting firm based in New York. Barbara has more than 25 years of international finance and development experience and has worked with organizations including Goldman Sachs, Chase, and BBVA. She has advised institutions such as IFC, USAID, and the ILO. Our fourth speaker is Shams Assad, Chief Operating Officer at BRAC Microfinance. Shams is leading BRAC Microfinance in a key strategic role that fosters digital transformation, diversified product development, delivery of client-centric service channels, etc. His work encapsulates the ideas to transform BRAC Microfinance, getting prepared to meet the vast needs of new generation of microfinance clients. Thanks to the 5 of you for having accepted our invitation and for taking part in this webinar. I have to say that we already had at e-MFP the opportunity to work with our speakers in the run-up to the award, and all your input has been invaluable to set up the 2021 edition. So thank you very much. And to our audience, we hope that you will enjoy and learn from this webinar as much as we have enjoyed and learned from our exchanges with our speakers over the past months. I'm going to give the floor to Bobby to start the discussions. Maybe just a few housekeeping rules. As you have seen, mics are muted and cameras are off for the attendees. You are very welcome to post all your questions through the Q&A box and throughout the whole webinar. Bobby and the speakers will be handling them either during the discussion or at the end when there is some time reserved for discussion with the audience. So thank you very much. Enjoy the webinar, and Bobby, the floor is yours. Thank you.
Great, thank you. I think to get us warmed up, we're going to start. We have 2 poll questions that we want to present to everyone. I don't know if Gabriella, if you can post those so that we can get those started. There we go. So both of them are there together. And so the first question that we have is, what is the benchmark percentage of household income that constitutes a catastrophic out-of-pocket expense? And the second one is, how many people are pushed into poverty annually from paying out-of-pocket expenses for health services? And if you guys can all answer those questions quickly, we'll look at the results and use this as an opportunity to frame the discussion going forward. Maybe we'll give it a few more seconds. All right. Does it look like we have most of the answers, Gabriella, so that we can post the answers that people gave?
Yeah, I'm going to end the polling now. We have almost everyone voted.
Wonderful.
And I will share the results.
You probably didn't know you were going to have a pop quiz when you joined the discussion today. Great. So we have the majority of people answering, about 20%, as the benchmark for a catastrophic out-of-pocket expense. And looks like there's almost a tie with 60 million and 10 million for the percent of people pushed in, or how many people are pushed into poverty annually each year. We can go ahead and move to the next slide, but I'll kind of give you the answer to number one. The research really shows that anywhere between 10 and 20% is the benchmark often used to establish a catastrophic out-of-pocket expense, with 10% being one that you see people use the most. And so that may give you an idea of how low that expense or the percent of that household income expense and the impact that that can have on a household if it's only 10% of an annual income. And then approximately 100 million people are pushed into poverty annually from paying out-of-pocket health expenses. And this was the number estimated prior to the pandemic. So as of the end of last week, it was estimated that approximately 3.2 million people had died from COVID. And so I know on a lot of our minds is, what is the role that we have to play both in the economic and kind of health recovery, especially as we keep our eye on, the achievement of the Sustainable Development Goals. And so it's estimated that approximately $80 per capita in low income countries is spent on out-of-pocket health expenses, despite all of the different national and universal health coverage programs that are out there. And it was estimated by the World Bank and the World Health Organization that governments really needed to increase their spending on healthcare by approximately 1%. And this was, again, estimated prior to the pandemic. And I think they estimate now that it's closer to a 2% increase that's going to be needed to really help countries bounce back from this pandemic. So there are four sources of healthcare financing generally that, we'll be talking about today, but that how people get healthcare covered. Number one is government spending. So the national health insurance schemes, the different, covering of free primary health care in different countries, private sector health insurance schemes, out-of-pocket expenses that people pay when they go to the doctor for a copay or to just cover medicines, et cetera, and development assistance. So your different programs run by NGOs and things like that. About 26% of households borrow money and sell assets to cover healthcare expenses. So this just kind of gives you a sense of how some of the out-of-pocket expenses are covered by low and middle income households. And then there's research that shows that women may actually face more discrimination when seeking healthcare when households struggle to pay for healthcare. So a research study in India showed that as households really faced difficulty in paying for healthcare, if it was a woman, they were less likely to actually have her go to the doctor. And so that evidence, I think, is growing as more people look at kind of the inter-household dynamics and how healthcare expenses are covered. So those stats just set the stage for the conversation that we're having today and the importance of thinking about how the financial inclusion sector can really support healthcare expenses. So if you can go to the next slide. So the main thing that we want to be able to do during this discussion is think about three kind of high-level questions that I'm going to raise now, because I think if you can think of your own answers to these questions, that will, provide us an opportunity to get a lot of feedback and ideas on these questions. And we'll kind of come back to those towards the end of the discussion. So the first question, that we had as a group is, why is the financial inclusion sector rarely at the table? So when you see a lot of publications and efforts by governments nonprofits and NGOs, et cetera, around the world, you see a lot of healthcare organizations, government entities talking about how are we going to cover healthcare expenses, and you rarely see financial service actors mentioned in those publications and at those meetings. The other question we have is, why is health financing so hard? And should that mean that organizations that work in this space, should it just be considered a niche area? So we hope that through this discussion, maybe we'll start thinking about some of the answers to these questions. We have a lot more to discuss. So I'm going to just go ahead because I'm most excited to hear from the panelists that we have today to gain from the experience that they all individually have around this particular topic. So if we'll go to the next slide, I want to invite Lisa Morgan first. And through this discussion, like Gabriella said, if you have questions, please enter them into the chat. We'll try to answer them if they're questions of clarification as we go along. And then at the end, we'll try to catch up with anything that we've been unable to answer as we go. So in 2018, Lisa Morgan and Craig Churchill had developed a paper on health financing and was really looking at how financial service providers complement universal health coverage programs. And they have this graphic in the paper that I thought, across my own research, that I thought was really helpful in thinking about the different ways financial service providers kind of click into universal health coverage plans or insurance plans that governments may be promoting. And so I'd like Lisa to kind of come in and share some of the experiences that they have in the research through their research that they uncovered, the various needs that households have and how financial service providers that you see in your research are actually responding to, complementing universal health coverage.
Great, thanks so much, Bobby. That was a really great, comprehensive introduction. So it's an honor to be here on this webinar. And yeah, just to say that, healthcare is very complex. It's a complex area. There are many different stakeholders involved in the healthcare sector, which I think is one of the things that makes it so hard. But just stepping away from the puzzle for a moment, just to give some other thoughts around the healthcare sector. Healthcare systems typically have three main groups of people in the system. So, those who use the healthcare services and those who pay for the services, that might be the same group of people if it's out of pocket. And then you've also got the providers of healthcare services who also need financing solutions. So for example, small clinics that need diagnostic equipment and perhaps need a loan with special arrangements to finance that equipment. But for now, I think just because time is short, we're going to put that aside and just focus on the clients, the typical clients that FSPs have who use medical services and how we're going to go about financing that. So in particular, we also, looking at low-income populations. And in our research, there were really two dimensions that would determine, which type of financial services provider and which type of product would be suitable. So those two dimensions are frequency and severity. So thinking about frequency, how often are you going to go to a medical provider for a particular type of procedure? And then how much, the severity, how much is it going to cost you? So the different combinations of those two dimensions will also help us navigate, the way through the options and this puzzle slide that you're seeing. But I'd also like to state up front here that, governments really need to play a leading role in the overall health system. And most governments around the world now have policies around universal health coverage and plans in place to reform the healthcare system along the lines of what the UN actually promotes with UHC, UN and others. But it's important to remember that when we're thinking about products and services, we mustn't create duplicate structures, and we must aim to really try and complement what the government is doing. Firstly, because when you think about a government, they can raise so much more money across the country through tax revenue, and it's going to be very hard to replicate that through any type of insurance. So, the first issue is really practically it's difficult, but I think also just showing some solidarity with the sort of wider national plans and how we can complement them. So back to frequency and severity. So for high frequency events, like for example, if you have expected things like, you're going to go for an eye checkup, or you're going to the dentist. These are things that are expected relatively high frequency and low cost. So these are the types of things that savings and loans could be used for, and they could be appropriate. For things that are more sort of moderate, severe, or acute illness, and even things like dealing with epidemics like we're seeing with COVID, or immunization programs. These are things that are more suitable for nationwide government efforts. But having said that, there is space where the financial services sector can complement this and help. So, for example, just thinking about the gaps, really doing your market research and understanding where those gaps are, and seeing, so for example, like hospital cash, where you can have very simple plans that cover some of the indirect out-of-pocket expenses. So like the cost of medicine, lost income, transportation co-payments, the cost of meals, these types of things which people still have to pay for out of pocket. And they can be quite significant, even if they are relatively small compared to the cost of healthcare. For low-income populations, they can be significant. So this puzzle really brings together everything that an FSP can think about. So on the left-hand side, we have enrolling with a UHC plan. The financial services industry can really help get people enrolled. And this is quite important in countries where you have low levels of formalization and people are outside of that social security system. So you can help with enrollment. For example, in Ghana, there's a way that you can, this is a project that we worked on. You can enroll in the national health scheme through your mobile phone using mobile money to pay for the small premium that's subsidized. But the financial services sector can help with this type of enrollment. And then there's your simple hospital cash type products. And building on that, you've also got these health loans and health savings that you can have at special arrangements that facilitate people accessing these services. But I think not to forget, value-added services is something we talk a lot about insurance. This is really, really valuable. And I think, often it's kind of just tagged on at the end as something that's tangible, but sort of like a marketing tool. But I think we've seen that telemedicine, for example, which is a value-added service that you can bundle with all of these things. Telemedicine, especially in times of pandemics where people don't want to go and see doctors in person, this type of value-added service, along with all sorts of health tips and other things, can be immensely valuable in preventing people from getting sick and providing them with much needed information. So the puzzle that you're looking at here is really part of what we call an integrated risk management approach. And we suggest thinking about bundling as many of these things together into a product that can offer a comprehensive service covering all of the different frequencies and severities of these healthcare costs. So I think, I'm not sure if I've hit my 5 minutes, but I'm going to stop there and hand it back to Bobby. Just one last thing. I think the other thing is that it's important to think about the risks that people face, the risks that your potential customers face, and help structure these financial arrangements to, even like when you think about the healthcare providers, avoid perverse incentives of, what motivates providers, and also thinking about how to, just how to help governments also in the financing of UHC. I'm going to stop there. Thanks.
Great. Thank you, Lisa. No, I think that's a helpful way to, frame the conversation. And as you were talking, and, I was reminded of, the differences, like you were pointing out, between the low frequency or the high frequency, low impact, and the low frequency, high impact, kind of helps us segue into the role that insurance, plays within the sector. And I know, Peter, both you and Lisa have actually everyone on this panel, I think, has quite a bit of experience in insurance. And I'm curious, when we think about insurance, Peter, can you share from your experience, what have been really the lessons that we've learned about offering micro health insurance to the within the sector, and where do you think this will go in the future, given even, in my own experience, just seeing this component grow and the creativity as to how insurance gets delivered, kind of now bundled with, M&Os in countries and different ways that, organizations are trying to find, ways to kind of limit the barriers for insurance. I'm curious, from your perspective, what is your experience about the lessons that we've learned so far?
Thanks a lot, Bobby. I'll be delighted to share. First of all, though, let me tell the audience that I'm not attending this call from my normal computer, but on a much smaller screen. So if you send questions to me directly, if that's even possible, chances are I'm not going to see them. So rather address them to Bobby. So That said, I think the first that came to my mind in terms of lessons is that need is not demand. It's hard to think of a more universal insurable need than people's health. Not everybody's a farmer, not everybody has a business or takes a microfinance loan, but every person, no matter your age or where you are, has a health to worry about. So you would imagine that people are interested in health insurance, health microinsurance, but when you start doing it, you find that it's not the case. And that is particularly disheartening because it's detrimental to the scale that you need. You probably know that microinsurance or inclusive insurance, as we more often say these days, is a high volume, low margin business, like selling prepaid airtime. So you really need to insure tons of people. And if you fall badly short of your planning, then your whole business venture will derail. Now, why is that? Some of it is comparable to insurance in general. So people have cognitive biases. If you've never spent a night in hospital in your life, you may think that it's not going to happen to you ever. You underestimate the risk that you're hit by a car when you step out of the door. People overestimate the present value of money, especially if your life is very uncertain. Then payment streams in a year down the line are much less attractive than if you live in stability of Switzerland, let's say. So you discount the future risks and you place a lot of value to the money you have in your hands today. The cost of ongoing health maintenance is also often underestimated. I think that happens to all of us. If you sit down and really take careful accounting of what it takes to keep your health and your family's health, it's often more than people are willing to pay for health insurance, no matter how comprehensive. A last point in this context I'd like to mention is that this was okay in the past, perhaps because informal networks of solidarity have worked. People have had help from family and friends, but as social fabrics disintegrate, because people migrate downtown, because families get smaller, that may no longer be working. Now, second lesson I'd like to share is that microinsurance just in itself requires to bring together two very different skill sets. You need to know about insurance, obviously, but you also need to know about poverty, about the lives of the people you're trying to serve. And that's not usually found in one office. Somebody in Peru, I think, once told me one of the big obstacles to microinsurance is that poor people don't work in insurance. And it's true. I can think only of one person in Brazil who apparently worked his way up all the way from a slum to being a director of an insurance company. So you need to have these two skill sets. But why am I mentioning this? Because in health insurance and health microinsurance, you need to add in another skill set, and that is healthcare. You need to know a bit about healthcare. For example, the availability or the quality of care and how to assess that, how to assess generic versus branded versus counterfeit pharmaceuticals. What profit margins do pharmaceutical brands have? And there's also an additional conflict of interest that you need to take into consideration. Usually people assume that there is a conflict of interest between insurance clients, insurance companies, and insurance salesmen. That's sort of the classic conflict of interest triangle. But when you bring health insurance, there's a fourth party that may have a conflict of interest, and that's the providers of healthcare. They may want to maximize their revenue, just like you think insurance company would like to minimize claims payouts, and sales agents would like to maximize their commission. The next lesson is that healthcare financing would be much more efficient or effective if combined with efforts to reduce inefficiencies in healthcare. There's a lot of wastage in healthcare. What do I mean? So one example is if you buy drugs in Germany. Last time I lived there, maybe the doctor prescribes 8, but they only come in boxes of 10 or 20. So if you need 8, they sell you the box of 10. If you need 11, they sell you the box of 20. And the remaining 9 are thrown in the bin or you stash them somewhere in the back of your cupboard. In the United States, that's different. If the doctor prescribes 13 pills, it's exactly the amount of pills you're going to get from the pharmacy. So that is an obvious improvement in efficiency. But you also know that the United States is the most inefficient country in terms of expenditure for health compared to health outcomes like life expectancy and infant mortality and things like that. So just scratching the surface here, that's something that should be considered, not just paying health expenses, but also trying to bring them down. Lisa also mentioned tangibility, value-added services. And many people see insurance as a zero-sum game. So if you paid premium, you want to get something back, especially if you're a first-time buyer. If you don't properly understand the difference between insurance and savings, for example, and you think, well, I've paid my savings money, I didn't use it. When do I get it back? When do I get the insurance premiums back? That's a reality that you come across often. And to overcome that, I think we found that adding tangibility can help. What do I mean by that? So helping people understand, for example, that premiums for insurance are not the same as savings, and that if you don't use the insurance, it doesn't mean that the insurance company just took the money to pay bonuses to executives, but somebody else is using it. But also value-added services and tangibility. What sort of things do you have? Somebody once told me healthcare is like a jungle, and in the jungle you need a guide. And I think that's very true. It said 15 years ago, and I still remember it, because dealing with the healthcare system on any level is not something you do all the time. So you'd like to know who is good at what they do, where you can get what sort of treatment, how is being treated fairly even defined. That sort of guidance, I think, is one value-added service. But there's other things like preventive care, for example. Now, with all that, proper health insurance is so resource-intensive that unsubsidized sustainability can be difficult. What do I mean by proper health insurance? I use it into parentheses, meaning in health insurance, that would cover almost everything. And that's what first-time buyers often expect. Anything related to your health is taken care of. Now, as Lisa said, that adds the frequency. So a lot of small claims for malaria cases, for cough, for digestive disorders or toothaches, that would need to be addressed by the insurance company, handled through claims assessment. And that costs an awful lot of money, an inordinate amount of money. And that's why you'll find a lot of carve-out health microinsurance, either the hospital cash that has become very, very popular only in the last 10 years. Before, I've been wondering for ages why nobody took it really up outside of Jordan, or hospitalization insurance. And this is where the other financial instruments that Lisa has mentioned come in already, namely medical savings, or to a lower extent, maybe medical loans. One other thing I'd like to mention is that the process is very important to customer experience, maybe more than in other lines of insurance. One reason is that you use health insurance more often, even if it's limited to hospitalization. You go to hospital more often than you die or die of accidents. So how it's handled when you use it is much more salient to the customer. But also things like case management. Once you are in the hospital, how do they take care of you? And it's not always clear to the customer what he's covered for, especially if you've already used the insurance. How much do I have left? Okay, thanks, Bobby. I'll try to cut it short, though. Two more points. One is that there's universal and there's local truths. Yes, I said everybody has a health to worry about, but when it comes to the details, they differ a lot between north and south of Pakistan and between this and that country of Africa, depending on epidemiology, on what people eat, on the socioeconomic transition to transmittable diseases, to cardiovascular diseases, to what governments and donors fund in healthcare, what cultural attitudes there are, for example, towards women's health, delivery, family planning, and all that. So let me share some thoughts about the future. Let me start by saying that, in my opinion, insurance is simply the transfer of information and the transfer of money. That's what it all boils down to. And I say this because I'm going to sing the praise of digitization. I was quite convinced of that when I put these thoughts together. I'm not so enthusiastic these days, but I'll come to that. Firstly, my first thesis is that finance will continue to digitize. And there's been lots of research over the last year how the COVID crisis and the lockdowns and government cash transfers have massively increased the use of non-bank financial, money transfers, cashless banking, let's say. I'm not going to list the evidence here. People are using digital financial services more often, people at all social levels. The second thesis is that healthcare itself will also continue to digitize, even more notably. At this point, I'll just quote or recommend you a paper by Gizma called Health Systems, Digital Health and COVID-19, again, stimulated by COVID-19, which shows just how many digital innovations there are in countries like Myanmar or Pakistan or Nigeria, most notably, something like 30 or so different health startups who are digitizing all sorts of things, from patient records to billing to providers and lots of others that I don't remember right now. And lastly, my main thesis is that coordinating these two is going to make the difference. The coordination of digitization of finance, including insurance, of course, and the digitization of healthcare services. And there's a number of papers there as well by USAID or by the British Medical Journal. And there's also this event by USAID again, where AXA reported about their COVID-19 response in the Middle East and showed just how much telemedicine had taken up during the last years. Just one example. And I'll stop it there. Sorry if I exceeded.
No, that was helpful, Peter. You covered actually a lot of ground in there. And as both you and Lisa were talking, I'm reminded of the question of why is this so hard? And all of those details make me think this is why it's so hard, because there's so many details to just pay attention to, because you're not just looking at the financial sector, you're actually looking at health behaviors, health organizations, hospitals, et cetera, that also face their own financing constraints. Earlier in the presentation, I presented the finding that, women may be facing discrimination in healthcare in particular. And I know, one of I always think of the one kind of statement that we use in the sector, especially if we're talking about women's empowerment, that money in the hands of a woman improves health, education, nutrition of the household, et cetera. And I know from our own research at Grameen, one of the things that really surprised me when we were looking at through a series of health diaries, that even though, certain health financing products are often geared towards women, either through savings groups or through microfinance institutions, that when it came down to actually paying for healthcare, women were rarely the ones saying that they paid for it, that they often, relied on their spouses. And so it kind of changed even my mental framework for, how do you market health financing products, et cetera, for the household. And so, Barbara, I know that you have a lot of experience just working in women's entrepreneurship. You've done a lot of research in insurance as well. And a lot of the studies that you did kind of, I think they're called math studies or MILT. I know that the acronym is MILT, but I can't remember. But I know, we're really looking at how people were using different financial products. And I'm curious, to this point about, what is the role of women and gender within this conversation? If you'll share a little bit from your own research and experience as to, what should we be taking into account? And then, what should we be doing better as we move forward and thinking about health financing in particular?
Great, thanks, Bobby, and thanks, e-MFP. I think that e-MFP is actually going to post a link to one of those presentations from the client math work we did with the milk study. If anyone's interested in kind of delving more, there are many, many studies on this topic that we were able to do with some funding a few years ago, and they're really fascinating if you're into this space. What I've tried to focus on, because health is a little bit tangential to what the work that we do, but it is such an important part of a household financing picture, right? It influences so many household financing decisions. And so we've been quite involved in it one way or another. And my focus, and where I think sort of our value add and one of the more interesting challenges, is to make sure that women are getting care for themselves. So, your comment about sort of family health is relevant, but the women tend to put themselves last in that sort of hierarchy of care. And that's something that is really interesting and important to me, is figuring out how to get them kind of higher up in that hierarchy through behavioral and financial tools. So that's kind of one of the intros that I wanted to present as I sort of go through some thoughts. The other thought that I have, and I think it meshes really well with what you were saying earlier, Bobby, is I really struggle with this paradigm about, women's versus men's expenses and who takes care of health expenses. I think that, we like to think of women as caretakers, but as we add more and more burdens onto women, so you pay for school, you pay for health, you pay for this, you pay for that, we forget that they're the poorest person in the family. And we're like really straining those resources at the household level into these expectations of care that perhaps are a priority for them, but they just aren't able to cover, right? So I really do like to move away from that when possible and thinking about who pays for what. And think about it a little bit more deeply, because ultimately we want not just women to pay for healthcare or to have financing options, but also men. And that involves or requires, you know, a lot of education and sensitivity building, right? Because men might not be in the daily sort of contact with health needs, and so they may not have the awareness of what health expenses are. And when you survey men, for example, versus women about health expenses, you often get really different responses about the same family's healthcare needs, because they're not looking at the cough syrup, the acetaminophen, the little things that sort of leak day to day out of the family budget. They might be looking at a surgery or an accident, a broken bone, something bigger that they might be more involved in. And so sort of building men into that conversation about health and kind of what that means is really important. And I think also because in our experience, when you offer women the choice, they will protect the highest income earner in the family, right? Makes sense. And so that might not be them. They might not be looking to protect themselves, and then they'll protect their children because they're their children and they love them. And so, you know, their priorities are also kind of skewed away from their own care. And that's something that we want to build into this awareness and understanding. I wanted to give a little anecdote. When we were in Egypt a couple of years ago, we were holding some focus group with microfinance clients in different regions, and we separated women and men, and we're talking about health, women and men's health, as well as children's health. And it was really interesting. We got very similar things. You know, women were saying they take care of the daily expenses, the daily healthcare expenses, mostly related to children. They tend to forgo their own needs and skip. And I think in countries like Egypt, where health infrastructure is relatively weak, there's certain things that they skip because there is no easy cure. So we were shocked by the stories around breast cancer and women just not even diagnosing, not even going to the doctor. You know, they find out they have a giant lump in their breast way too late and know that this is kind of a, death sentence, and that's just the way it is because there's so few treatment options in the country anyway, right? But the types of sort of thinking around health are very much focused on the family. And they also said when there's a big expense, they go to the husband, they talk to their husband, they, negotiate with their husband. So what that has led me to think is that to the extent possible, if we can bundle some of these products with other products, from an acquisition perspective, we probably would be better off. I know Juan had a question earlier on the chat, on the Q&A about, demand and supply and how do you kind of get the demand? It's always easier to force demand, right? And to make things mandatory as much as possible. Might not be able to make it completely mandatory, but maybe by bundling something in with a loan or giving access to a health loan, for example, if you pay for certain insurance over the course of a year, it might incentivize people and also give them an excuse to say, I'm doing this because I have to, not because I want to, right? And it's sort of like, here's my justification for paying for something that might be helpful for myself that I would otherwise not prioritize or want to pay for. So my thought on acquisition is very much around bundling and thinking about where you can kind of come up with ways to bundle smartly some of these care issues. The second part, though, which I think is also critical, is utilization, right? You can have lots of products forced onto people, but in some ways, when you bundle, you get even more. You're even more challenged with the utilization problem, right? So I have a product, but I'm not using it. And why don't people use it? And I think there we really need to work on making products more usable. And a lot of that has to do with opportunity cost, in my opinion. So I remember just very clearly a market vendor in Guatemala that I spoke to. It was kind of a heavy lady who has her booth in the market and had a very swollen leg. And I asked her about the leg and she said, I don't go to the doctor. I'll go to the doctor the day I get out of bed and I can't walk. And that's obviously like a poor process for from a health perspective. You want to get that stuff treated and looked at early on, not once the woman can't walk anymore. But it really spoke to opportunity cost. I have to leave my booth. Somebody's got to take care of my booth. I may have to pay someone, or maybe I don't, I close it down. I don't make money for the day. So there's a real high opportunity cost to getting care. Maybe you get the care to come to her, you know, as a way of reducing opportunity costs. Maybe you think about, you know, some additional payments and, you know, really designing a product in a way that takes into account those opportunity costs and make sure that people have both the incentive to purchase or the requirement to purchase, but also to use the service. One of the things, and this is what I wanted to point to in the chat link that e-MFP spoke about, and I won't get into it in detail because you could look a bit more in detail there, is about slices and kind of attending pathologies and slices and how that can also help reduce opportunity costs and kind of behaviorally incentivize people to go seek care. So for example, we were looking at a product in Ecuador some years ago that was a primary care product, and we found that people really didn't value it and didn't appreciate it and were often frustrated when they did use it. And the reason for that was that you would be sent to a primary care clinic that was sort of higher quality than a public clinic to get some tests or diagnoses or, you know, whatever, just treatment for smaller events. But no matter what, the patients were then sent to labs, and significant number of labs. Why? Because they hadn't been to the doctor in a decade or more. So of course they have all sorts of stuff that needs to be looked at. You know, they need to be tested for a whole bunch of stuff that's been delayed. And when they get the bill for those labs, we're talking about hundreds of dollars. So yes, the insurance covered that primary care, but it didn't cover those next steps. And there were some intermediate steps before you can maybe access a public service. And so you're really creating a lot of frustration, a lot of costs, and a disincentive for utilization. So the way I like to think about coverage is, rather than covering kind of horizontal slices, so primary care, labs, surgeries, inpatient care, you know, kind of critical care, et cetera, in these kind of generic cost-based layers, or the way Lisa was talking about frequent and infrequent, there's always going to be some kind of distortion in the utilization when you do that. So if you cover only really critical care, you might be telling people, don't go to the doctor until you're about to die, because that's when it's covered. And so you're actually getting really bad health outcomes. If you're covering just primary care, you might disincentivize them to go because they know they're going to be like additional costs that aren't covered. And so rather than doing that, we've been looking at like pathologies and saying, okay, we're going to cover just like a really narrow pathology, but we're going to take it from prevention to primary care to labs and testing, medication, more, you know, kind of critical urgent care, surgeries, et cetera, all the way up, so that once you sort of start that process, you are covered all the way through and you have the incentive to continue that process. I'll stop here because I'm sure I spoke too long.
No, that's really helpful. And something, you know, as you were talking, struck me when you were especially talking about kind of the care burdens that women have. You know, in the same research that we did in the health diaries in India, you know, we had asked them the question, you know, how much responsibility or say do you have in how, you know, you seek healthcare, and then, you know, would you want more say? And actually, I was really surprised. Most of the women said, no, I would not want more say, because that means I'm responsible. Like, the more say I have in it means I'm more responsible for those healthcare expenses. So again, it just, you know, kind of flips the narrative a little bit about, you know, trying to put more responsibility or more opportunity on somebody's plate, and, you know, having potentially an adverse effect on just somebody's mental well-being all of a sudden. So I think we'll go to Shams, because I know we're running tight on time. Shams, just with, you know, BRAC is one of those organizations that I think inspires many of us outside of Bangladesh, and so much of what has happened in the sector is really modeled over a lot of the work that you guys do. You know, you work in health, but you also work in financial services. And a few years ago, you know, you guys had put out a paper on the development of a health loan within BRAC. And, you know, some of the big questions that come up about all of the different innovations that BRAC has used is how much of, you know, your model is actually replicable outside of BRAC and in other countries. And I'd love to hear a little bit about your practical experience of what you've learned, maybe specifically about the health loan. Like, has the way that product was designed, how has it evolved and changed over time, as well as any other kind of health financing products that you guys might be providing?
Right. Thank you, Bobby. So just getting into the detail of the answer, I'm just giving two information before that in a country like Bangladesh, the percentage of out-of-pocket expense in total health expenditure is quite high. It's 67% from a national estimate. And also yearly 5 million people fall into illness-driven financial catastrophe every year. That is a kind of average. So when in BRAC, we were developing a medical treatment loan product back in 2013. So for our clients, for the communities that we serve. So a couple of things we were considering before designing the product. So I'm just getting straight into some of the ground experience that we had during this pilot. So one thing we tried to understand that whether could we get into the decision-making process of the household when there arises a need of health financing, and also at the same time ensuring that there is no purpose drift when the financing option is available. So very simplistically, we felt that there are 3 stages of this shock recovery. It started from diagnosis, then the treatment, and also post-recovery. And we felt that financing can be required at any stage, and how we can stand beside the households and help them to take a better decision so that it doesn't lead to a stage of over indebtedness. So we came up with a solution that, as you already mentioned, that we have a separate health program. So we made this model like that. The client needs to go to a BRAC endorsed doctor, and from doctor's endorsement, there would be a suggested amount that will be required for the recovery, and we will be disbursing loan based on that suggested amount. And at the same time, we also came up with just to control the expense. We also came up with a range. It started from minimum $50 to maximum $600. And if a requirement is more than $235, so we came up with a mechanism to disburse in 2 phases. In the first phase, it can go up to maximum $235, and if it is required more, then we'll do another disbursement. And at the same time, we kept flexible options of repayment from 6 months to 24 months. But typically, our regular products are 12 months. Some of the products are for 18 months, but we tried to make it a little more flexible. So and at the same time, we started offering this product to the clients who are having a current loan with us, and also who are having also the group who are having only savings with us. We started the loan with those clients. So this was version 1, Bob, and that was triggered back in 2013. So after a substantial amount of time, we got some experience from that pilot. Now we have a version 2 of the product. So some of the learnings I wanted to share, that is the model of getting endorsed in a BRAC specified doctor becomes very challenging for many households. And there are many reasons, sometimes it is traveling, the distance they need to travel to go to that doctor in a specific geography, or sometimes the availability of the doctor or the appointment timing, it clashes, especially in the rural setup. And in many instances, households also have their own preference of doctors. So that was some learning from the first pilot, first design. And at the same time, the loan cap that we had, at some point of time, we realized that it was not also very flexible, because sometimes the demand is more. And this model of disbursement in 2 phases, this was also not very much client-centric, because it depends on the context, it depends on the disease the client is going through, that sort of variables. And lastly, what we thought that in the first version, we excluded the new clients who were never been with BRAC, but we realized that why not a client who can start with BRAC with a medical treatment loan. Doesn't matter. It all boils down to the repayment capacity. So these are the few changes we made in version 2. So for the loan cap, or for the requirement analysis, we tried to came up with a model of analysis based on these variables that we all know what we microfinance institutions usually do. It's a combination of, expenditure, then income, current debt situation, also the savings amount they have with us. So we develop a tool for the field officers so that they can sit with the household, and based on this permutation and combinations, they've come to a plausible amount that is required by the family. And of course, one more important variable here is the tenure, how long they want to take it. Because in most cases, our study says that in 87% cases, the household who are asking for the loan, they already have a loan with BRAC. So after redesigning, we installed this version 2 in a different set of branches. Then we found that in the version 2, the loan uptake was increased by 10% compared to the version 1. And at the same time, we found that at any given time, of the client base, 3.7% clients are asking for this loan. And the average loan size was $150, but we saw that it went up to a maximum of $950 at that point of time. So we also saw that 45% of the need was coming from the age group of 31 to 40, and 32% are coming from the age group of 41 to 50. We also did a wealth scoring for all the families in the client group who are asking for the loan and who are also not asking. So the households who are getting the loans, what we observed that these households are pretty much at around the poverty line of international standard, that is $1.9 per day. So it gives us the confidence the loan is going to the right type of households. And also we saw that we observed that in terms of occupation, 30% of the households were daily wage earners sort of households, 20% were involved in agriculture, 13% were micro merchants, 14% were job holders. So 37% of the
maybe one more minute.
One more minute.
I'm watching the clock tick down and realizing I'm not leaving a lot of time for questions.
Yeah.
Sorry.
Yeah. So what else we saw that in 57% of the cases, the women were using the loan for themselves, and in 22% cases they were using for their husbands, and 13% for their children. And typically, mostly the reasons were lower back pain or gynecological issues, surgeries, childbirth, or cardiovascular. These were the things. And also we observed that 60% of the household at certain point of time fully recovered, and 35% were partially recovered. And there were also some death incidents during the pilots. So these were pretty much broad learnings from our pilots. And right now with the version 2, we are thinking that we are in a confidence stage to scale it up nationally.
No, and I think, as we think about kind of the answer to, what makes this so hard, like just thinking about the time frame that you just spoke about, starting in 2013, and you're really at kind of version 2 in 2021, and thinking about the scale up, just the time that it's taken to kind of watch how it functions, and is it working the way that we want to, so that it just doesn't become a product that gets put on the shelf, in hopes that people, maybe use it. So Gabriela, I realize I've done a really terrible job of trying to keep people at 5 minutes. And part of that is I just find everything that everybody said is interesting and valuable, to this conversation. But I wonder if there's, a question in the Q&A that maybe we can answer before we close down the webinar. And I would hope that maybe after this webinar, we might, find an opportunity to maybe seek the people's perspectives on the answers to the question, maybe through a blog, or I'm putting work on your plate, but I can imagine there's a lot of appetite for actually getting more answers to kind of some of those bigger questions. But Gabriela, is there a question in the chat that maybe we can answer before we close down?
Yeah, well, Bobby, you still have 30 minutes, so no need to rush.
Oh, I do? Well, then why am I thinking I'm like, oh my gosh, it's 9 o'clock my time and I've done a terrible job. Perfect.
No.
It's a 90 minutes.
All
right.
Yeah.
Well, then let's take a Q&A.
Yeah,
And
sure.
Shem, so sorry because I cut you off. If there are
No, it's all right.
opportunities
It's
for you to
all
get
right,
into
fine.
more detail,
Yeah.
I will totally let you take the stage.
So there are just a couple of questions more. If you could share the research that have been mentioned. So maybe, Bobby, they want to know the research you mentioned on women struggling to prioritize health in India. And now Francisca asks about the health loan paper. I think you mentioned that BRAC had a paper. One thing we can do is we can share these resources afterwards. We can publish them with the webinar materials, no problem. But yeah, we have a couple of questions. One is from Natalie, who explains that depending on the context, sometimes financial service providers may achieve greater social impact by supporting preventive health measures than through health financing. And she explains the example of Foncose, where their client network's penetration into rural Haiti is virtually unparalleled by any institution, even the government, and it puts us in a unique position to support clients' health, in our case, beyond health financing through partnerships. And what Natalia asks is if the panel has seen examples or data in which FSP's bottom line is enhanced by supporting clients' health in ways that don't include financing. So this is the question from Natalie. Then we have a question, now questions are increasing, so maybe we'll go a bit better. And another from Amelia, a question for BRAC. If, Shams, if you have found specific ways of explaining or marketing health products to be more effective in explaining the value of the products to clients. So there are a couple more questions. I see Barbara is typing to reply to Juan Vega. They are having an exchange. Barbara already mentioned it. And maybe there is another question for Shams. And if BRAC received a specific funding to design and launch the program.
So Shams, do you want to go first, since two of those questions are directed at you, and then maybe we can go to Natalie's question, since I think various people will have answers to that.
So the first one that about marketing the product, it happens in a typical microfinance setup that the women come into the group and field officers talk about different products and services. So that's the way actually a typical microfinance institution do the promotion of a product. So usually in a rural setup, people do not expect to get formal financial services in terms of medical emergency, with the fear that I'm already having a loan with an institution, they are not going to give me one more. So that is the usual mindset. But the field officers, they have a very big role to make the clients understand that how to take decisions in such a situation, at the same time as a responsible organization, how we can help them. So that is the marketing channel we typically use. And for the funding part, actually we did it with our own money. So it was not funded by any investors or anything like that. Yeah.
So Shams, maybe you and Barbara, and then we'll get to Natalie's question. One of the things that's come up for me is, given this conversation about women needing to take the responsibility for maybe taking the loan for the household, to pay for health, and the question about marketing, how much does BRAC even support the women in discussing taking that sort of product on behalf of the household? So is there any sort of engagement where maybe the husband is also engaged, since maybe the loan is being taken out for somebody else in the household? Or is the loan covering anybody in the household health expense, or just the client?
As I said, that it covers the household members as well. So in 30% cases, we saw that the money was used for the sickness of the husbands of the clients, and in 13% cases, it was spent behind the children. So another thing what we do that probably some of you know, that we before the loan disbursement, the client needs to come to the branch officers, and there we have a pre-disbursement orientation, which is kind of financial literacy thing. So right usage of money, and in terms of shocks like medical emergencies, that point is quite well covered in that financial literacy training. So these are the ways we try to actually talk about how to handle shocks and how to use the money. So these are very typical ways in this country setup,
Yeah, one thing, if I could just add that we have to be really careful about, and I see this all the time, is when you have people from a microfinance institution or any other kind of intermediary in a developing country, you know, you're professional, middle class, educated, you have access to better healthcare, and you tend to put a lot of kind of bias on the type of care that people typically will use, like public health services, and try to push people into private with the quality kind of angle. And that's great if you're not draining all of their resources or putting them in a spiral where their costs are actually going to be much higher because, you know, that quality care is only partial coverage, and then you have to pay for extra and everything else. And, you know, I kind of see that with these numbers too, in terms of just like, if you're draining with a health loan, that loan for the use of children and husbands, but you're not recommending preventative care for women, follow-up care for women, then even if women have a pretty severe situation, they may not ever take out that loan for themselves, right? So how do you build those incentives to make sure that women are accessing that care? I think that's a really interesting question.
No, and as you know, as Bobby said in the beginning, that in BRAC we have a separate health program, and we have a separate microfinance program. So the health program, they really engage the women on the household on the total household's healthcare issues. So here we have all the things like, you know, neonatal healthcare, prenatal healthcare, then women healthcare. We try to cover all those things, but you're also right that in our version 2 of the product, what do we observe that the total expenditure in formal healthcare channel has increased significantly. But in the version 2, where we try to cap the informal expenditure in the informal channel was, you know, informal channel was 60%. But in the version 2, when we remove the caps, formal channel expenditure went up to 90%. So that is something we observed, you know, when we there is a general tendency to go to the private channel and spend more over there. There is a general tendency, of course. You're right.
So Lisa, on Natalie's question, maybe I'll let you start, given, you know, some of the research that you've done. I'm curious if you have kind of a thought, and I'm actually blanking now on what the question was, since Gabrielle asked it earlier, but I think it's like experiences of other FSPs either playing a role in the non-financial services, right? Was that the question?
That's the question. So maybe just while I answer it, if you could bring up that slide again, if it's to hand with the puzzle, because I think that'll also just help me answer it. So that's a really great question. And actually, I'll just wait for the slide to come up. So yeah, if you look to the right-hand side of the slide, we've tried to list the most common types of value-added services, which are typically the sort of non-financial services. And some of these have actually shown to be quite effective. So for example, let's just take a look at the first one. So we've got reward schemes to incentivize healthy behavior. Now, this is not a microfinance example, but if you look in the paper that this comes from, there is an insurer in South Africa called Discovery Health. They have a vitality scheme, which is basically like a wellness scheme. So if people do certain things, they get certain points, and then this in turn helps reduce their premiums. So that's kind of roughly how it works at a very high level. But what it has shown is that by offering certain incentives, it can be a win-win for everybody, because it can help the clients be better, well, help improve their health. It helps the bottom line, and it helps society at large. It's like a three sort of level win. Now, you might say, well, yeah, that's really nice, but that's kind of like a middle income solution. But actually, there's no reason why this type of thinking can't be applied in a lower income setting. So, for example, I see elements of this being developed, like Triggerize, for example. They're an organization they're a non-for-profit organization that are working in 12 markets in sub-Saharan Africa, and looking at certain activities where people can be rewarded for doing the right health-seeking behaviors. So, for example, pregnant women going to their prenatal checkups, using mosquito nets, that kind of thing. If you're interested to see how that works, I invite you to go back to the paper where this comes from And you can look online and see if there's sort of any updates since we wrote this paper. But I think, you know, these other things like telemedicine, where there is service that you're offering, health tips, you know, even discounts, that can be another thing where you have negotiated discounts at certain pharmacies or clinics, or certain retail stores. These are things that foster client loyalty. So you might find that actually your retention of clients is improved by the fact that you're offering these non-financial services. So I think that's certainly like with, you know, the mobile phone distributed health insurance, the idea of offering all of these other things that maybe they're for free, like with Tonic in Bangladesh. Like if you have a phone, you can access a certain amount of hospital cash cover and telemedicine or health tips. You know, the idea of that is that it will help the company as well, because it will improve customer loyalty and hopefully increase their ARPU. So, you know, I think these value-added services definitely have the potential, in some cases have shown, I mean, it's very difficult to prove, but I think that they have shown in some cases to definitely help with, you know, not only the health of the customer, but also the bottom line of the insurer or the finance institution. So perhaps others want to weigh in with their experience.
Mm-hmm. And I wonder, and maybe this is a different question, and I'm happy to go back to this because I figure there can be a lot of discussion about it, especially, you know, something that comes to mind for me is just the tendency of different financial institutions that maybe used to provide these integrated non-financial services, like due to regulation, have split apart. And so all of a sudden you see what used to be integrated now being offered by like the NGO arm of a financial service provider, you know, whereas the financial services component of it, you know, stays with the financial institution. So maybe we come back to that, but I do have before I forget, a question maybe for Peter and for Lisa. You know, you had mentioned earlier, and something that surprised me when I was thinking about insurance and all of, I think I'll have to find the ILO publication, but it was a kind of like that big lessons learned about microinsurance paper that I think was put out a few years ago. And one thing that struck me about that, and Peter, I think you mentioned it, or maybe it was Lisa, about, you know, really it's the day-to-day, the frequent health expenses that tend to push people into poverty, just the burden of kind of the ongoing health costs. And, you know, so much of what I've seen, if there is an offering of health insurance, it is just for hospitalization. And so that's kind of that, you know, low frequency, high impact. But if you were to have a recommendation for financial service providers, would it really be to start there, or would it be to look more at these kind of short-term expenses that maybe they're better off covering? If they're thinking about, where do I put my time and effort? Do I put it just going to hospitalization insurance, which it seems to be what's most on offer in the sector, or starting with more of maybe that hospital cash or some other type of insurance?
Sure. I'll have a go at answering that, and then Peter maybe can add.
Sure, go ahead.
So I think from the ILO's perspective, you know, it's not one or the other. We're really trying to experiment with and pilot this idea of an integrated risk management approach. So how do you, if you look at this puzzle, how do you bundle together as many of these elements together into one place so that you can try and help people cover all bases? If you've helped enroll somebody into a national UHC scheme, that base for the very high expense, the very low frequency but high expense, is going to be covered. If at the same time they can access telemedicine, and they have an accident that happens in the home and they can quickly call a doctor, you know, that sort of minor, potentially minor thing can also be dealt with. If they know that they need to be saving up for an annual eye check, you know, having a savings account that they can specifically use for that, maybe even it's only intended for you know, certain medical providers, that can offer you know, the solution. So I think if time is going to be spent on this, thinking about it more holistically is probably a good thing to do. And if you can't think of it holistically, I would just look at the value-added services. That would be sort of the advice that we would give. But Peter, please do weigh in.
Yes, let me start there perhaps. According to all the statistics that I know, 60% or more of people's healthcare expenditures on pharmaceuticals. So if you can reduce the cost of them accessing pharmaceuticals and the quality of the pharmaceuticals, you're doing them a great favor already. Now, that said, I also agree that a holistic approach would be the best, and it would be great if everybody lived in countries where governments offer universal health care, and there's a reasonable way of helping them become members of that. And that's the future I'm hoping to see one day. Still, if I had to choose, I believe that the more impoverishing events are the major one-offs. It's true that we all are faced with a constant drip of healthcare expenditures. All of us, things go wrong. And I also believe that the more frequent side of that, like going to the dentist in Switzerland, is something that needs to be addressed with liquidity management rather than insurance. And consequently, I had no dental insurance in Switzerland. So when I needed to go to the doctor, I had to cough up a couple of hundred Swiss francs, which I could do. And it wouldn't have been any cheaper if I had bought insurance for that. I do believe that the major events that lead Indian farmers, for example, to sell their land and take up a miserable life as rickshaw drivers are cases of cancer or accidents, or this, the cancer case that Barbara mentioned with the women in Guatemala. But the different difficulty of that is, while I believe, and I think research shows that this is what pushes more families into poverty than the constant day-to-day cases of malaria or children's dysentery, people don't see it that way. They don't appreciate it the same way. So even if you bend over backwards, what I believe we did at the Aga Khan, to find the best possible, most effective, cost-efficient, low-margin ways to cover that, people don't quite love us as much as you think they should. Let me finish with one thing. The real difficult thing, I believe, is chronic disease. So that's people, and unfortunately, that's a growing number as nutrition starts to move to more high-calorie things and so on. The case of diabetes, to just quote one, in India and Mexico, pretty much everywhere, they're going through the roof. And this is very tricky to try to address with a solidarity scheme like insurance. Why should anybody else pay for those people who already have diabetes? My father occasionally tells me just how much he costs his health insurance in Germany because he's a diabetic. And I think it's something like 6,000 euros a month. So what do you do with the people who have chronic disease already at the moment you put in place some scheme? And how will you preview that going forward, knowing the numbers go up?
Thank you, Peter. And just for everybody's information, if you want to leave this webinar feeling really jealous, you should feel jealous of Peter because he's doing this webinar sitting on a balcony overlooking a beach right now. So for many of us, dressing up to stand in front of our computer in our house, we're all feeling a little bit jealous that we're equally not sitting and staring at the beach right now. Maybe with a pina colada at 9 a.m. my time. Sounds great.
There's no pina colada involved here. But since you bring it up, Bobby, I could seize the opportunity to address a question that I managed to see in the chat about the scale. Somebody, I think from Cabo Verde, asked, what can you do in small countries? And yes, I'm sitting in a Caribbean country here of a population of about 70,000, and it's by no means the smallest. So the Caribbean is scattered with really microscopic countries, and they do have financial services that work. So my first answer to that person is there's a strong difference between insurance and other financial services, and that is that insurance really needs the law of large numbers. That's a mathematical concept that allows you to predict the future in a way that you don't have to predict with savings or loans. Yes, there can be some loan defaults, and you don't quite know what your investment in different savings instruments is going to yield, but the predictability is much greater. But if you just take 10,000 people and say, each of you is going to pay 500 cedis, and if any one of you needs to spend more than 2,000 on health, we're going to use this money to pay for you. You have very little idea if these 200 cedis you're taking from everybody are going to be sufficient or not. The best you can do is recur to this law of large numbers, take past statistics, and then use that law to help you guess what the outcomes are going to be in 1, 2, 3 years and how much money you need to cover that. And for that, you really need more than 20, 30 people. So the answer to the question in Cabo Verde, as I recall it, is you can have savings and loans, I believe, in countries with 500,000 inhabitants or 70,000 inhabitants, and I know of plenty of countries who have, if your margins allow to serve that loan portfolio. And with the Aga Khan, I remember in some countries like Burkina Faso, we had portfolios that weren't terribly big. So depending on the margins or how efficient your administration is, I do believe that you can do savings and loans in a country like Cabo Verde. Can you do health savings and health loans? That will depend, as I said, on a lot of local circumstances. For example, the medical infrastructure. What is there to keep people healthy in the first place? How do doctors and laboratories charge? How much margins can they get away with? How much are people inclined to go to traditional herbalists instead until things are so bad that it's really expensive to fix them? A number of things. But to finish on a hopeful note, there's no reason why Cabo Verde shouldn't be able to implement good healthcare financing systems.
Great, thank you, Peter. And maybe, I think we've got, if my time's right this time around, we've got about 10 minutes left. And maybe, Barbara, I'll start with you. I mean, kind of going back to the questions that we started out with, I'm wondering, I think we all see potential for financial service providers to play a greater role in health financing. And I wonder from your perspective, why you think the financial sector is not at the table, and should we be at the table when there are conversations that are happening at the national level about, health financing, health coverage, et cetera, just from, your own experience kind of working in between some of the research and the, kind of practical practitioner view?
Yeah, I mean, I think it's a very complex question. If we look back at the last decade and a half, I think that the financial sector and microfinance in particular has been told that they are, the sort of poor sibling of the banking sector, and that they need to professionalize, they need to be lean, they need to have higher margins, higher returns on equity in order to maybe meet the needs of investors so that they can scale. I mean, we have a very market-based kind of old-fashioned, I think, sense of what microfinance has to look like and what social business has to look like that I think today's younger generations are going to challenge and question, and we might start seeing a little bit more innovation. But what that's led to is actually very limited innovation, only around very specific things that are really scale focused, right? And providing health services, whether it's education, whether it's loans, whether it's insurance, requires time with clients, explaining things to clients, talking to clients, giving them materials, negotiating deals with providers, a whole bunch of stuff that diverts your operational efficiency into these services that may have a lot of social value. And as Lisa says, maybe helps client retention. We don't really measure that very well, but it is not seen as, market optimal. And I think that's the culprit, honestly. I do think that's going to change. It's going to have to change, because as we move into a more digital world, microfinance institutions really need to figure out what their role is. And yes, they can all become fintechs, but who cares? There are millions of fintechs out there, and there are millions of banks that can have digital products and services out there. Why is a microfinance institution different? And the only reason a microfinance institution is different is because it has the trust of their clients, and that it develops that trust in a way that is not fully digital, in a way that includes human interaction, and that includes a certain level of empathy for those clients. And so as we think about what microfinance could look like in the future, we might start to say, oh, it's a social business. Well, we've agreed in the business world that social businesses may be able to forgo a little bit of profit in order to have other types of outcomes, but we haven't agreed that in the microfinance world yet. And so I think that these kind of processes and evolutions, thank God for these young people who are changing the way we think about markets, will influence the sector, and does offer hope for getting involved in some of these more socially optimal interventions. But that's what's holding us back, in my opinion. I'll shut up. I'm controversial.
No, I think that's fine. And Lisa, I think you said you had a response for Peter on the NCDs.
Yeah, so
maybe while you're at it, you can also maybe think about adding on to Barbara's about, then does that mean anybody doing health financing, maybe it's a niche area, just given all of the complexity.
So, okay, I'll keep that in mind. So I think just going back to what Peter was saying, so yeah, people just have to think back to what he was saying about his dad having diabetes, and my dad also has diabetes, so clearly we've got unhealthy parents here. But yeah, I think the research shows, and various WHO reports are showing NCDs are rising in all countries across the globe, and I think this is also this can also be about knowing your client and knowing what healthcare issues your clients have. And that's not too difficult to find out with a bit of market research. And I think when it comes to NCDs, again, this is, these can be pretty known expenses. If you know you have diabetes, you're going to know that in time there will be certain expenses that you can expect. And so, there are things you can do with that. You can have a savings account that is linked to the care that you need for diabetes. And with the value-added services, this also, there are wellness programs out there, all sorts of programs out there that are being developed by one micro-insurer or inclusive insurer in mind that I have, but I don't think I'm at liberty to say yet. But, there are things that are being developed that can help people manage particular diseases. So I think thinking about how you can weave that into what you do could help. And then back to Barbara's comment and that question, I think, there is so much work to be done. I mean, there's such a huge funding deficit when it comes to achieving the SDGs. I think it's a case of all hands on deck. So I would say, microfinance institutions are not the central organizations that can be fixing the healthcare system. I mean, I think we have to be realistic about, where we positioned in the ecosystem of health. But I think we can be, we can really help facilitate things and connect with the membership base that is out there. And by being that aggregator, being that conduit and that agent, I think there is a space for us to make a difference in the healthcare system. And that shouldn't be underestimated. And I wouldn't say, let's just leave it to the niche. But at the same time, if you don't have that expertise, I would be very careful going into it. But I think at the very least, sharing health information is something that everyone could do, and that should benefit everyone at the end of the day.
Well, and maybe even what you're saying is that, I mean, it kind of makes me think of it differently in that, microfinance institutions may be in a better position than a lot of social enterprises because they do have that trust and they kind of have this constant touch point with a population that other fintechs and other, types of financial service providers may not have. And so then they may be able to kind of think more of that bundled package more than any other institution and kind of cover things more comprehensively if you can both make the financial case for it and the benefit that comes out of that. Because I wonder, for those that are able to provide the insurance as a top up to airtime or something like that, like that's part of a package, but they're not able to do the other things necessarily. Like it's just kind of part of the ecosystem, that maybe exists. So Shams, maybe now we're actually at, I think 1 minute, right, Gabriella? So I'm officially on time with, maybe I'll let Shams kind of have the last word here. And I think one of the questions in the chat, and I may reword it wrong, is really about, the way people behave in terms of, they really don't like to pay out claims. They want the money at that time, one of the things that I've heard in conversations around health financing is we really shouldn't be doing loans. We don't want to indebt people. There should be other types of products. And so there's kind of an aversion to loans. And I'm just kind of curious from your perspective, given the work that you've done, kind of what your perspective would be on, what the role health loans play in this conversation.
No, I think this is a very good question because I give you two examples that in our context, we have an estimate that there are 40% multiple lending. So considering that, in BRAC, we thought that why not we develop a top-up loan product. So we introduced a good loan product, which we called Good Loan. So client having a one loan, she can avail another loan. It didn't fly out because of the field officers. There is a huge resistance to disburse another loan having already another loan outstanding. So that product did not fly out. Now we are again we tried with an emergency loan in response to the flood affected people. Whenever flood arises, it can be disbursed as an emergency loan. It didn't also fly out because in a situation of flood, so many variables occur in a community. So you can't just have control on many of these things. Okay? It didn't also fly out. Now we are again trying with another product that we are calling, seasonal loan. That is in terms of seasonal needs, a client can avail that loan with a stoppage of repayment for 3 to 6 months, and it can be paid as a one-off payment. This one is showing some encouraging results. So probably at some point of time, it can also help the microfinance institutions to cater to certain needs of the households. But whenever in consideration of the health needs, we feel that there are resistance in the ground among the field officers, because their mindset is to safeguard the loan amount and collect the money back, rather having the broader mindset of standing beside the household when it is the real need. And also the huge group, we are excluding the loan defaulters or who are missing schedules. We are not yet providing the loan products to that group of clients, but they are also in need of money. And at the same time, many of you know that BRAC has a separate program called the ultra poors. So for the ultra poors who are living way below the $1.9 per day scale, so there the health financing needs are quite acute. And this group is not even ready to take a regular microfinance loan, not yet. So in our model, after 2 years graduation, they graduate to a stage of taking a normal microfinance loan. But before that, they are not ready. So yeah, definitely, these are questions we are trying to figure out through our all these experiments. But the one that we have right now, the version 2 of the product that we are having right now, so we are seeing some encouraging results, but it lot depends on who is talking about the product, how that product or benefits is taken up to the clients, and how we are connecting the bridge between the service provider and the client. These things are really very important. Otherwise, if you launch something, it might fly out in the initial 6 months, but again, it might also die out in the next 6 months, because it gets away from the top of the mind awareness, both from the service providers and also in the client's mind. It happens.
Yeah. No, thank you so much. And I know that we're over time, so I just want to say thanks to all of the panelists for the really interesting conversation. And I'm glad we had the extra 30 minutes than I helped create the agenda, so I'm not sure exactly how I missed having more time than what I thought I did. So just want to say thanks to everyone. And Gabriella, I'll pass it over to you if there's any just final word from your side to close us out.
Well, thank you. Oops, I'm trying to put the video. So thank you, Bobby. Thank you all for the excellent webinar. I hope all the attendees have enjoyed and learned. We will be publishing the recording that will be available on our website. And I will also ask our speakers a last favor, and is to share with me all the resources that have been mentioned, because we have had several requests, and we can publish the link or the name to these papers together with the webinar presentation. So thank you very much to everyone. Apologies for the couple of minutes delay, but I think it was worth it, and special thanks to the 5 of you for an excellent discussion. Thank you very much.
Thanks,
Thank you,
everyone. Have a
Gabriela.
great night,
Thanks,
great rest of
everyone.
your day.
It was a pleasure.
All right, bye-bye.
Farewell.
Bye-bye.
Take care, everyone.
Bye-bye.